I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine, a program dedicated to bringing the cutting-edge medical topics to the Staten Island and tri-state area. Thank you all for watching. Tonight's topic is going to be about obesity and hypercholesterolemia, two very large topics that affect the world and affect the people of New York and Staten Island specifically. About 40% of people in the United States are obese. About 70% are considered overweight or obese. About 40% of people have high cholesterol levels. So this is a very common process. We have two wonderful guests here, guests who have been here before, and I want to thank them for coming back.
My pleasure.
We have Dr. Lena Lakina, who is an attending physician at Richmond University Medical Center. She's a fellow of the American Academy of Clinical Endocrinologists. Hope I've said that right. And Dr. Philip Otterbeck, who's the director of the Division of Endocrinology at Richmond University Medical Center. So welcome. They're both endocrinologists. And on a daily basis, they deal with people who have obesity problems, who have weight problems, cholesterol problems. So a lot of times when the internist or your family physician has problems controlling weight, your weight, controlling your cholesterol levels, beyond some of the routine things that we do, oftentimes they'll be sent to a subspecialist, or a specialist in this case, who's an expert in the management. So welcome and thank you both. So we're going to jump into this very, very complicated, very large topic. Tell us about obesity. What's its definition? How do we know if we're overweight, if we're obese?
So the way we define obesity is using something called the BMI, the body mass index. And essentially what it is the relationship between a patient's height and their weight. You know, for the folks out there, they can get their calculators out, but it's essentially their weight in kilograms divided by their height in meters squared. And they can also Google BMI, and then all these BMI calculators come up, and they can just put in their data if that's easier for them. But essentially, when a patient has a BMI, when you plug in all that data and the BMI is greater than 30, we would say the patient is obese. When their BMI is between 25 and 29.9, we would say they were overweight, and less than 25 we would consider to be of a normal weight.
Mm-hmm. What causes obesity? Is it genetic? Is it just what we eat? And what are the factors involved?
As you said, this is a huge topic. There's certainly genetic predisposition. There's also environmental influence as well, and the decisions patients make on a daily basis. The studies that have been done on moms who are obese or don't follow ideal diet during pregnancies show that their children are at risk for developing obesity after birth. So if you think about it, this developing fetus is at risk for obesity even before being born. So environment plays a huge role, but there's also genetic predisposition to obesity. And so you certainly have to take into consideration that if there is genetic predisposition, or if the child was exposed to some sort of environmental problems growing up, then it may be more difficult for that child to maintain healthy weight throughout their life. However, at the same time, the decisions that this individual makes on a daily basis play a huge role into what will happen to this individual's well-being. And so the decisions they make as far as physical activity, the decisions they make as far as food intake, sleep-wake cycle, also very important. So there's a whole science out there defining what plays into risk factors for obesity, and then obesity itself is a huge risk factors for many other illnesses that stem from it.
So Dr. Otterbeck, so talk to me. Talk to us all. Is it bad to be overweight? Is it very bad to be obese? We know, of course, when we watch people who are over 400 pounds, or whatever cutoff, 300 pounds, we know there are risk factors. They can't walk up a flight of stairs. There's a lot of medical issues, comorbidities that we see in the hospital. Where does it become dangerous? And how do you decide when someone needs to be treated? And we'll talk about the treatments at length. And I think what Dr. Lakina was basically saying that it's not, that's a healthy lifestyle rather than it's just a treatment for obesity. And I think that's where we all go. But tell us a little bit, when should someone worry? If they do this BMI and they're a few pounds overweight, should they be very anxious about it? Give us a little idea about that.
I don't say that the patient should be anxious about really anything, but I think that when you're in the overweight category, when you're certainly in the obese category, your risk for severe diseases, deadly diseases, increases dramatically. What are those diseases? Well, one of them is diabetes, which Dr. Lakina and I also treat. One is high cholesterol, one is hypertension, another is sleep apnea.
What's sleep apnea?
Sleep apnea is a condition where generally an overweight or an obese patient, when they go to sleep, generally their significant other will tell them, listen, you snore at night, and not only do you snore, but you stop breathing. And sleep apnea, what it does is the patient overnight will actually literally stop breathing, and their brain then needs to wake them up and say, okay, you have to start to breathe again. And this can be dangerous. It puts stress on the heart, puts stress on the body. It actually, in and of itself, can result in an abnormal heartbeat called atrial fibrillation. So this condition, this sleep apnea, is treatable, certainly, but the best way to treat it is to prevent it. And the way we prevent it, in many cases, is to prevent ourselves from getting overweight and obese.
You mentioned diabetes, and you're both experts in the field. Does weight control help disorders like diabetes?
Absolutely. So there are obviously many types of diabetes, but regardless of the type of the diabetes, weight control is very, very important. For example, for type 2 diabetic, weight loss can be curative. And the same applies for, to take you outside of diabetes realm a little bit, for a patient with polycystic ovarian syndrome, weight loss could be curative. They wouldn't have to take medications. They wouldn't have to suffer with potential complications. For other types of diabetes, weight loss is also very important. You will find that patients with type 1 diabetes or other types of autoimmune diabetes report that it is easier for them to manage their diabetes on day-to-day basis. They don't find it challenging to control fluctuations or wide fluctuations of their blood sugars if they stick to a recommended diet and some sort of an exercise routine. So weight loss as well as maintenance of healthy lifestyle is very, very important for any diabetic of any type.
So you said diabetes type 2, that's more, I know there are no general rules, more the adult or older onset patient. Type 1, usually a little bit more of the younger onset.
Correct.
And you're talking about some of the complications, and we have a model here today. And our model is here as an artery. And this is an artery where we see the hole being fully open. And after years of other diabetes, obesity, high cholesterol, which we'll talk about in a few minutes, we see this yellow fatty plaque that closes this off. And if this artery is in your heart, you'll have a heart attack. If it goes to your brain, and being a neurologist, I see this on a daily basis running our stroke center, that we can get a stroke. And this could affect multiple parts of the body. So our goal with weight control and other things that we do is really to keep these arteries open. And that's such an important fact that we talk about. So once we decide that someone is overweight and we're concerned or obese or morbidly obese, which means very obese, different definitions that we use, what do you do when someone sits down? It's so hard. Physicians are always rushed. There's always a question. Which doctor, what type of doctor should really be treating this, first of all? And then we're going to talk about what they should do with their treatment. What kind of doctors are usually involved?
And I think the front line of all our healthcare, I think, is the primary care physician. And I think primary care physicians really need to focus on this, because if they can focus on this one piece, essentially you're treating all the other pieces. So if you're treating their obesity and helping them to lose weight and exercise more, then you're treating their diabetes, you're treating their blood pressure, you're treating their cholesterol. So you're hitting all the other comorbidities of the disease when you treat that one diabetes. So the primary care doctor is at the front line. And then, of course, there's a subspecialist. Certainly, patients are referred to Dr. Lakina and me when there's a question. Should this patient be initiated with a medication? Should we consider this patient for bariatric surgery? Is there another disease state that's going on that is resulting in this patient's obesity? And those are things that we're asked to tease out.
So let's go really into the meat of this. So are there other diseases that can cause people to become obese? Are there any hormone problems, thyroid problems? Tell us a little bit.
So one of the most common that we'll see is polycystic ovary syndrome, which is generally a disease of young menstruating women who have irregular periods. Sometimes they have excess facial hair. They get a darkening of the skin around their neck called acanthosis nigricans. Those patients tend to be overweight, and they're very sensitive to carbohydrate consumption. Other diseases that can cause obesity are Cushing's syndrome, and it's a very rare disease. It's a tumor either of the adrenal gland or the pituitary gland, and that produces an excess of a hormone called cortisol. And cortisol can cause, in and of itself, obesity. Additionally, we have patients that have hypothyroidism. In some patients with hypothyroidism, there can be a modest weight gain associated with the condition. And
is that common? Because a lot of my patients, everybody thinks they have a sluggish thyroid. That causes it.
Well, it's very easy to test. We have special blood work that we use, and we assess the thyroid gland, and certainly if there's an abnormality, we treat it. But if we have normal circulating thyroid hormone levels, we should not attribute the patient's obesity to hypothyroidism in the context of normal circulating thyroid hormone levels.
So now back to someone's obese, they want therapy, they want to lose weight.
Yes.
They see all these diets on television.
Yes.
We see all these famous people doing this and losing X amount of weight in X amount of days. What are your recommendations? First, let's talk about diet issues. Do any of these, I don't know if they're considered fad diets, or how do you define these diets, and what do you recommend to your patients?
So current recommendation is really not to look at this process as a diet, but more of a lifestyle modification. Certainly diets out there have great potential. The most commonly recommended diet is a Mediterranean diet. And so patients, when they come to see us, a lot of time is spent counseling, even before the diet is introduced and the exercise regimen is discussed. Because patients are to understand that a diet for a couple of months is not going to solve their metabolic problem, is not going to reduce their potential for risk of complications of obesity and associated conditions. They have to be ready to say, okay, today I'm going to make a lifestyle change. We also counsel them to make a realistic change, right? We all know about sort of a cosmetic disturbance of being obese. People want to look good. They want to fit into a dress for an occasion. So diets are good for that kind of short-term solution. If someone is to make a change in their life to decrease risk of or reduce risk of complications of obesity, it has to be a lifestyle change. So we usually advise patients that if certain recommendations are not realistic for someone's lifestyle, people work different shifts, have different environments, different social lives, then the unrealistic lifestyle change should not really occur. Out of a list of recommendations, they can pick, I would say, 80%, and they certainly would be successful with the lifestyle.
So do they leave
change.
your office with a diet, with a sheet, how many calories to take? I mean, how does this all work? I mean, I know different things. I don't know, we're not promoting anything specifically, like Weight Watchers, Nutrisystem, whatever I see on TV.
Right.
Are any of them better than others? Not better than others. Are they better than the fad diets? Are they something that you recommend your patients to go to?
They're really nothing but a well-balanced diet. So I usually tell patients, if you want to call it Weight Watchers or Jenny Craig or Nutrisystem, they're all great systems. But patients have to realize that at some point they're going to stop purchasing that program, either in form of meals or advice, and they have to be able to say, okay, I've learned what I need to learn, and I will continue doing what I have done based on what I have learned. I can't tell you that one is recommended over the other, but Mediterranean diet is what we usually give patients references to. But as you know, this is a one-time visit is not going to solve the problems. If someone is making a lifestyle change, it takes a lot more guidance, right? And so these days the model is to have a comprehensive center where you see an endocrinologist, you see a dietitian. Patients always have challenges. Think about revolutionizing your lifestyle. They have to be able to come back, maybe sit down with a nutritionist and say, you know what, I try to eat what's recommended, but just don't like it. So there have to be alternatives. We have to work with these patients. And so it really is individualized, comprehensive approach rather than saying here is what you follow for breakfast, lunch, and dinner, as we probably did in the past.
You mentioned the Mediterranean diet a couple of times, and as a neurologist, my literature talks about the people on the Mediterranean diet having lower risks of things like Alzheimer's disease, stroke. Tell us what's in the Mediterranean diet.
Mediterranean diet is actually very easy to maintain. You just have to restructure what you eat a little bit. So it consists of eating whole grains. Meat consumption is reduced to mostly poultry, and red meat is not recommended to be consumed often, maybe about up to twice a month or so. Plant-based diet, so plant-based meals to the patient's liking. Again, the patient has to really like what's offered, and if not, we have to work with them to see if there's anything more acceptable. They also have to review their fats, right? We all know about good fats and bad fats. Our patients these days are quite educated. They're making these educated decisions. They already come to see us having read the labels and read about trans fats and all that. So they have to review, as part of the recommendation for Mediterranean diet, they have to review their fat consumption, and they have to understand what the good fats and the bad fats, and sort of aim for better or poly and monounsaturated fats. They also have to review their dairy products, and they're recommended to consume dairy products with less fat in them. So that's it really is quite easy to follow. They just have to sort of restructure their mind towards it.
So the next step, if someone just really doesn't do well on the diet, we're not people who want to give medicines to everyone, but some people will need medication or some other treatments. So tell us, Dr. Odervik, tell me about some of the treatments. Let's talk about medical treatments. When do you decide to do what's being your next step? Dr. Lakina eloquently talked about diets, exercise, change in lifestyle. If that doesn't work, and it doesn't work in everyone, what's our next step, and when do we decide to go there?
So the medications that are available, and we have several now, about 6 or 7 drugs that are available on the market to treat obesity. And these are actually mostly approved to be treated for obesity as a chronic disease. That is, they're approved to be used for as long as the doctor and the patient want to continue them. And the patients that I would select for this certainly are the folks that are in the obese category, but actually they're approved to be used actually in the overweight category when patients have a comorbidity. So if they have diabetes or they have high blood pressure, we can safely and appropriately use these drugs to assist our patients. Now, how do they work? Well, as you know, Dr. Perel, one of the appetite centers that we have in our body, the main appetite center, is in the brain, in the hypothalamus. And what these drugs do is bind to receptors in that hypothalamus and induce satiety. They make people feel full. So in making people feel full, they are not as prone to going and getting additional food. The drugs are variable in terms of their efficacy. Some of them result in about 5, 7, 9% weight loss. Some of them are pills. Some of them are injectable agents. But they are reasonably safe, reasonably effective, unfortunately quite expensive, but they can be, for the appropriate patient, a very efficacious approach as an adjunct to the diet and exercise. Always we have to remember diet and exercise is the center of this, and the medications can assist us along in getting to where we would like to be.
Let's go on to the next stage. So we have diet, lifestyle changes, we talk about medicines. Now we're talking about surgery. If all else, tell us when you send your patients for bariatric, which is the term for weight reductions type surgery. When do you make that decision, Dr. Lakina?
So exactly the way you described it, we offer a lifestyle modification, we offer medical treatment, and if all fails and the patient remains obese or obese with complications of obesity, they become candidate for surgery. So Dr. Adebeck mentioned BMI. We calculate the BMI, and there's a certain number we use in association with complications of obesity or not, and that helps us make that decision. So for example, if the patient has BMI over 35 and has complication of obesity, whether it's the diabetes or high blood pressure, or obstructive sleep apnea, that makes them a candidate for surgery. If the patient just has a high BMI resistant to treatment, such as 40 and above, even without any complications of obesity, although that is quite rare, that makes them a candidate for bariatric surgery because potentially they will develop complications.
What is
of
bariatric
obesity.
surgery? What do they actually do?
So bariatric surgery is also sort of a growing field, and there's a lot of interesting new techniques out there. Traditionally, patients were offered either a lap band, where there's a sort of a ring-like structure put around the stomach, and there's a way to control its lumen to tighten it up or loosen it up. And naturally, as the stomach, as the access of the food into the stomach decreases, patients would eat less or maybe be satisfied with less of a meal. And so that was probably one of the most non-invasive techniques, and it offers a certain percentage of weight loss, and the patients learn that as they go into the introductory session to meet with a bariatric center. Another procedure that has been traditionally used is Roux-en-Y. It's a bit of a more intense alteration of the abdominal anatomy. So stomach gets physically altered, and so part of it gets to be removed, and the small intestine also gets to be anatomically altered and reattached at a certain point to the stomach. And so that in turn creates a smaller passage for the food. Patients are obviously satisfied with a smaller meal, and the release of the hormones that gut is responsible for also gets altered immediately, and so patients see results immediately. It's quite an extensive surgery. There are certainly more potential complications of it compared to the lap band. And so again, patients, when they go for the introductory session, they actually are shown presentation about it. They get to see pictures. They get to learn about potential side effects. Obviously, the more extensive the surgery, the more weight loss you would expect.
And the surgeon really helps decide. You're involved in the choice, but the surgeon sort of sees the anatomy and tries to figure out what would be the best procedure for
Absolutely. But for you, the patient, to be involved in the choice, you have to learn a lot to be able to sort of manipulate these terms and whatnot. There's also a sleeve procedure that's routinely done these days. It's not as extensive as Roux-en-Y, but also not as sort of a gentle or conservative as a lap band. It's one of the most commonly performed procedures currently. And what they do, they basically make that stomach is nothing but a pouch, and so they make that pouch smaller. And once that occurs, patients' food intake is less, and they eat smaller meals, maybe more frequently, and so they are able to achieve quite significant weight reduction.
So we've come a long way in weight reduction. I mean, we talked about medicines, we talked about surgery. I'm going to jump a little bit. Okay. When we talked a little bit about this, and I think if you do have a problem with weight, talk to your internist. If it's not working out, go to a specialist like an endocrinologist, and just take their guidance and to see what to do. But people who are overweight also tend to have high cholesterol levels. And having two experts here in the field of lipids, which is fats, how do you measure cholesterol, or how does someone know that cholesterol is high? Is cholesterol bad? Is it an evil thing? When we were growing up, eggs were bad. Now eggs are good. You know, margarine was bad. Butter was. You know, everything has gone around. Yeah. So tell us what we're up to now with regard to lipids and cholesterol.
So to test your lipids, it's quite simple. It's a simple blood test. Generally speaking, it's done in the fasting state in the doctor's office. You go, get your blood done, and then the doctor can give you an assessment. How is your total cholesterol? How are your triglycerides? How is your LDL, which is the so-called bad cholesterol? And how's the HDL, the so-called good cholesterol? And we should talk probably about what that means, bad and good. We alluded to our artery a little while ago. We noted that the lumen, how the blood flows through the artery, is impaired by when it gets clogged. And this is clogged by the LDL, the so-called bad cholesterol. But of course, there's a good cholesterol, and that cholesterol goes around and it actually sucks that cholesterol out of the arteries and opens it up. So we want to have high good cholesterol and low bad cholesterol. Now, with respect to diet, there's a lot of components that go into the numbers that you get. A lot of it is actually related to your genetics. And unfortunately, genetics we can't change. So I have very heavy patients that actually have perfect cholesterol values, and I have very thin patients that have terrible cholesterol values, and this is a function of their genetics. But of course, that's not every patient. Some patients, because of their weight, do have higher cholesterol values, and certainly they can
The trend is the heavier patients will have higher cholesterol.
That's the trend, yes. And certainly you can adjust your cholesterol levels based on diet and exercise, but of course there are medications to assist us as well.
So what percentage of cholesterol, say your number, everybody thinks of the number 200, total
Yes.
cholesterol.
Yeah.
With diet and exercise, how far down could you go?
It's a tough question. There are some studies that say that you could get the number down by maybe 20%, but that's not every patient, and some patients, they just produce so much of it genetically that they're not really able to move the needle very much at all. And some people tend to be much more sensitive, but on average, I would say it would be probably more difficult to get it down more than 20% on your own.
So if we can't get down to a number and we're thin and we're exercising and doing everything else,
Yes.
medications, and actually let me tell you, there's one other kind of cholesterol that some of our audience always, and my patients talk about, and that's triglycerides.
Right.
What is that?
Well, we see triglycerides going high in many of our patients. Those tend to be people that are what we would say is insulin resistant. And we have a profile of high triglycerides, low HDL, and kind of borderline high LDL. And those are patients, when you have that profile, those are patients that I would really, really look closely at and monitor for diabetes over the short and the long term.
So we have to watch this, a different kind of fat triglycerides.
Correct.
So if we want to get our cholesterol, total cholesterol, the bad cholesterol down,
Yes.
what do we do for patients? We talked about diet. We always want to do that.
Yes.
Exercise programs. In the last couple of minutes that we have, tell us about the medicines that are out there and what new things are available.
So we have a bunch of medicines available. The main drug that we use these days to lower cholesterol values, but also to prevent heart attacks and strokes, are the statin class of medications.
And give us some examples, like Lipitor.
Lipitor, Crestor, Pravastatin, Zocor. Those are the trade names. But essentially, these drugs have been very, very efficacious at lowering the numbers, but also preventing outcomes, preventing strokes and heart attacks and all the things that none of us want. There's another class of medicine called ezetimibe that works in the gut. Zetia is the trade name. This works in the gut and lowers the LDL. Very, very well tolerated therapy. And of course, now we have newer injectable agents. Some patients, for one reason or another, can't tolerate the statin therapy, whether it's because of myalgias or
So
aches
muscle
and pains.
pain. Let's use the muscle
Yes,
pain.
muscle
aches.
pains.
So if you,
Yes.
so Dr. Lucchini, if someone you give someone a statin,
Yeah.
and they just aren't doing that well with it,
Yeah.
and diet hasn't worked and everything else hasn't worked, tell me what are these new medicines that Dr. Otterbeck was alluding to?
First of all, as you know, different statins have different mechanism of being cleared from the body. So if one statin may have given a patient side effects, the recommendation is to try another one which pathway is different as far as clearing from the system, and that may just work great. If the patient cannot take statin or cholesterol is not acceptable on the current statin, there are these drugs called PCSK9 inhibitors. And
Long name, a lot of numbers and things. Yes.
and they, what they do, they actually alter the receptors that liver has for cholesterol, and so a bad cholesterol gets cleared quicker from the body than it would have otherwise. These medications would reduce the risk of cardiovascular events as well as other complications related to
And that's
high
available now.
cholesterol.
So all the medicines you mentioned, all these medicines are available now.
That is correct.
And so for patients who have difficult to control cholesterol levels, there are enough agents out there right now that it seems like you're able to get it done.
Right.
whether it's through some of the milder agents, the statins, right, and even people who have strokes, we use high doses of these statins in order to try to reduce the risk of a recurrent stroke. So I'd like to, really close right now and say thank you to both of you for being here. It was really marvelous to have experts in the field. We all want to try to have good health for our patients, our audience, our wonderful people who are watching us. And there are a lot of ways to get there. And we talked about diet and exercise. And with cholesterol management, everyone's been so afraid their number. Everybody thinks about their numbers like their IQ number, their SAT number. But there are ways to get your cholesterol down in order to live a full and healthy life. So thank you both. It was a pleasure to have you both here.
Thank
and
you
I'll
for
see you on
having us.
rounds tomorrow at the
Yes.
hospital.
Okay.